Herkese günaydınlar. Bugünkü interaktif vaka tartışmamızda 3 önemli konuğumuz var. Önünüzde keypad'ler olacak. Keypad'lerden interaktif olarak bunları tartıştığımız zaman keypad'lerde 1, 2, 3, 4, 5 diye cevaplar olacak. Ve onlara cevap vermenizi rica edeceğiz sizden. Eğer cevabınızı değiştirmek isterseniz tekrardan basmanız yeterli. 10 saniyelik süremiz var. Good morning again. Welcome to Turkey and our beautiful city Antalya. We have very distinguished panelists here. Let me introduce them. Dr. Marek Babjuk from Czech Republic, Dr. Sedalar from Netherlands, and Dr. Juan from Spain. All panelists didn't see the case before. I prepared 2 cases. The first case, prostate cancer, and the second one is bladder cancer. If we have enough time, we will start with prostate cancer, and then we will keep going on bladder cancer. These are not very rare cases, extreme cases, but educative cases. We will discuss the cases according to AUA guidelines or EAU guidelines. Okay, let's start first with the first case. 62 years old male, past medical history none. He doesn't have any surgical history. His first PSA was in 2015, 4.5 nanogram. And then after 1 year, his PSA was 6.03 in 2016. And urologic evaluation, the physical examination was with normal findings. Digital rectal examination was 5 millimeter palpable nodule on left node. Urinary ultrasound, there was no pathological findings. And next. Keypad'lere basabilir misiniz rica etsem? The first one, antibiotic and alpha blocker treatment, then repeat PSA test. Second option, transrectal ultrasound guide biopsy. The third option, multiparametric prostate MRI. We will wait for the audience. ...168 kişi katılmış. Ben buradan sonuçları şuradan görebileceğim galiba. Peki. Evet. %57 oranında trans-guided direkt biyopsiye gidelim demişler. %8 antibiyotik ve alfa blocker treatment var. Ve %35 de multiparametrik MRI var. O zaman panele soralım. Dr. Babjuk, do you agree with the audience? They decided to do directly biopsy, or any other panelists?
Yes, probably yes.
Yes.
The man is 62, he is healthy. Maybe I would like to have the third PSA because there were two measures, I think. What I'm used in these situations usually to have some more parameters coming from PSA, including the prostate health index and some more information. But generally, this man is a candidate for biopsy if really the PSA is in this value. And the question is whether perform the trans-guided or with MRI fusion. It depends from local habits in this moment. I think we have some project on an MRI fusion in primary tumors, but the criterium is not no palpable node in the prostate. So this is some project. So and it is in our countries reimbursed the MRI fusion biopsy only as a second biopsy. So.
Dr. Sedalar, would you consider to do a MRI or go directly transrectal ultrasound biopsy?
Well, there's nothing wrong with the transrectal guided biopsy. He's got an increasing prostate, a PSA. It's 62, a healthy man, but we would perform an MRI first.
MRI. Okay, let's see the MRI result. They did an MRI in 2016. The prostate volume was 35 cc. They found a Pyrus 4 lesion on left mid-gland, 7 millimeter, no finding of extracapsular extension, no finding of capsule invasion, neurovascular bundle or seminal vesicle invasion. So they did a 12-course biopsy in an outside hospital, and the result was prostate cancer, Gleason 3+3, 6, adenocarcinoma, 11 core left apex, 0.6 centimeters, 60% tumor, and 12 core, 0.8 centimeter, and 78% core tumor. Okay.
Can I ask a little bit about the biopsies? So were the biopsies done with the knowledge of the MRI? So was it, let's say, a sort of cognitive fusion where you know?
They didn't do fusion biopsy, but with the knowledge of MRI, yes,
so
of course.
They had knowledge of the
It was an outside hospital, not in my hospital, but it was, yes. So, okay, I will ask the panelists. Dr. Juan, what do you think about, is this patient, is a in low-risk patient, very low-risk patient, intermediate, or high-risk?
Okay, according to the DAMICO or the EAU guidelines, it's a low-risk patient. His BCA is below 10, Gleason score is 6, and but according to the digital rectal examination, you have a node, right? You have
okay.
You have a T2 at least in one side of,
yes.
of the prostate.
I will show you EAU guidelines.
Yes.
Okay, according to EAU guidelines, as Dr. Juan told us, it's in a low-risk patient. PSA is less than 10, Gleason score is less than 6, 7, and it's CT1 or T2 disease.
Yes.
It's according to guidelines, it's a low-risk disease. If you compare AUA guidelines, the only difference, the AUA put very low-risk patients. The main difference, the AUA accepts very low difference, very low-risk patients, but it should be, PSA density should be less than 0.15, and no core more than 50% should be involved. But according to AUA, this patient is again in a low-risk patient. So what is next? What will you do with this patient? Watchful waiting, active surveillance, radical prostatectomy, radiation therapy, and focal therapy. Keypad'lere bir daha basmanızı rica edeceğim. So, according to normograms, this patient is in a low-risk group. Evet, 145, 157, 159, bayağı bir katılma, 165 kişi. %71, 174. Peki, durdurabiliriz. Çok vaktimiz de yok. Evet, cevapları alalım. Bir kişi %5 watchful waiting demiş. Aktif izlem %29. Evet, radikal prostatektomi %63. Çoğunluk radikal prostatektomi demiş. Radyoterapi demiş, fokal terapi. Peki, panelistlere soralım. I am asking to you all, but we don't have time. I will request to give short answers to make it as fast as we can. Do you agree with the audience? Most of them, the majority, decided to do radical prostatectomy operation. Do you consider active surveillance? This patient is a low-risk patient.
Me personally, I would discuss with the patients all options, which is radiation, radical prostatectomy, active surveillance.
Active
I don't remember
surveillance?
how many positive cores there were too, so
Okay.
he is candidate for
Dr. Silva?
active surveillance as well. But the patient should decide, I think. In my view, the radical prostatectomy in the relative young man is a good option and possible option if patients agrees.
Any different idea from the panelists?
No, I think active surveillance should be at least considered, and I'm surprised that 1/3 says active surveillance, 2/3 says radical prostatectomy. In the Netherlands, it would be the other way around: 2/3 active surveillance, 1/3 radical prostatectomy. This is a candidate for experimental focal therapy, so there are some devices now, some techniques now where this patient could fit in. But like Marco said, it's a shared decision making. You give all the options to the patient, and together you try to come to a conclusion.
I agree with my colleagues. Probably I would discuss with the patients all the options that he has, but probably after assuring that the patient has a low risk disease, because I don't have much clear if this biopsy was cognitive guided or not with the MRI. So after making sure that it's a low risk disease, maybe with a rebiopsy guided with the MRI, and if it's confirmed, probably this patient in my department will undergo active surveillance.
Okay. According to AUA guidelines, active surveillance criteria, this one is feasible or not. So for the guideline, Gleason scored 6 and less than 2 or 3 cores and less than 50% positive core in any single core, clinical T1C or T2A, and only AUA guideline PSA density should be 0.15. It looks like there should be no extracapsular extension, lymphovascular invasion, biopsy, intraductal carcinoma, sarcomatoid carcinoma. So it looks like it fits the guidelines. We can offer him active surveillance or not. But the audience wants to do radical prostatectomy. Let's see. If we decide which type of radical prostatectomy would you perform, anybody will do open, how they want, laparoscopic, robotic, perineal. This is, I think, surgeon's choice. But my question is, should we perform lymphadenectomy? Yes or no? If we decide to go radical prostatectomy. Bir daha keypad'lere basar mısınız hızlıca? Çok vaktimiz yok. Lenfadenektomi yapacak olursak bu hastaya yapalım mı, yapmayalım mı? Eğer radikal prostatektomi yapmaya karar verirsek. Evet, büyük çoğunluk yapmayalım diyor. Düşük riskli radikal prostatektomi yaparsak da lenfadenektomi yapmayalım diyor. Okay, Dr. Juan, I will ask you, how we are going to decide to do a lymphadenectomy or not?
If we follow the guidelines, if it's a low-risk patient, this patient should not undergo lymphadenectomy.
Do you look at nomograms or not?
Yes, we use nomograms, especially in those
Okay.
patients.
I will give you a nomogram. Do you want it?
Yes.
Okay. This is Brigante nomogram. Let's put the patient's value on nomograms. Do you want to see his points? 50. If we calculate his points, it's less than 1% risk. If we use nomograms, this patient doesn't deserve lymphadenectomy. The audience are right. So, do you want to see another nomogram? Memorial Sloan? Let's see it. Memorial Sloan Kettering nomograms. His point is 80. Predicted lymph node involvement risk is 2%. If we look at guidelines, do we have to do, and if we decide to do a lymph node dissection, do we have to make a limited standard or extended lymph node dissection. Arkadaşlar lenfadenektomi yapmamaya karar verdik ama eğer yaparsak hangisini yapardık bu hastada? Limited mı, standart mı, extended mı? 1, 2, 3 diye hızla basar mısınız? Rica etsin. So, Dr. Marek, if you decide to do a lymph node dissection in this patient, are you going to do a extended, standard or limited lymph node dissection?
I think to be correct, guidelines say that if the risk is less than 5%, you must not do lymph node dissection.
If you decide to do.
So if I decide, then I usually do something like the extended lymph node dissection.
Extended?
So I usually specify where is the ureter and
Okay.
go down from the ureter and try to take also the lymph node from the internal area.
Okay. Let's see lymph node dissection. %38 limited yapalım demiş katılımcılar arasında. %39 standart yapalım demiş. Maalesef çok az bir kısım %23 extended. Şunu açık ve net söylemek lazım. Bütün guideline'lara girmiş olan şey. Eğer lymph node diseksiyonu yapılacaksa mutlaka extended yapmak lazım. Artık standart ve limited lymph node diseksiyonun yeri yok. Let's look at the guidelines. The risk of metastasis over 5% is the indication to perform a nodal sampling by an extended lymph node dissection. Don't perform if it's less than 5%, but strong recommendation. When necessary, do an extended lymph node dissection.
The question, just to interrupt you. The question is the terminology, whether we all are talking about the same here in the room, because what is standard, what is extended, what is limited. I think the terminology is not always so very clear.
Okay. So, in 2016, robotic radical prostatectomy was performed in an outside hospital. The Gleason score was surprising. It's 3+5. The tumor volume was 20%. The MRI was wrong. It was bilateral seminal vesicle invasion found in, maybe they couldn't detect this. But the margins were negative. And stage was T3B with negative surgical margins. Upgrading of prostate cancer from biopsy to final pathological stage is 36% in literature. This is very high. We have to be very careful about this one. So let's pass this. We don't have time. Yes, the patient had seminal vesicle invasion and T3B disease with Gleason score 8. It looks like he has high risk of metastasis. Evet arkadaşlar, bir daha keypad'lere basabilir miyiz? What will we do with this patient? Şimdi. He is asking a question about that.
Tanı anında yanlış mesaj verildi. Çünkü EAU guideline'ında biyopsi öncesi multiparametrik MR yapma weak recommendation. Dr. Sedalar dedi ki ben rutin olarak yapardım. Siz de dediniz ki evet bu dış merkezde yapılmış, MRI yapılmalı. Nodülü
Demedim,
olan fizik
dış
muayenede
merkezde
EAU'da şunu söylemek
Hayır,
istiyorum.
hayır,
Yanlış
ben
mesaj şöyle oluyor.
öyle söylemedim ben ama. Yanlış anlamışsınız. Dış merkezde MRI yapılmış ve dış merkezde sonradan biyopsi yapılmış. Benim yaptığım bir şey yok bu.
Tamam, ben şunu genç arkadaşlara düzeltmek için söylüyorum. EAU guideline'ında 62 yaşında PSA'yı 6.2 olan, fizik muayenede nodül olan birinin
İngilizce şey yaparsan Selahattin, paneldekiler de anlar.
MRI'ya gerek yoktur. Dr. Sedalar said, I will perform a multiparametric MRI before truth-guided biopsy. But the AAU guidelines suggest week's recommendation performing multiparametric MR in a patient with PSA level of 6.2 and abnormal findings on the physical examination. So ben diyorum ki genç meslektaşlar açısından bu hastaya direkt truss guided biyopsi yapılmalı. Bu birinci yorumumdu. Çünkü gereksiz yere multiparametrik MR'a gönderiliyor. En azından EIU guideline de önermiyor. Yani bu önemli genç arkadaşların truss biyopsi yapmayı teşvik etmek açısından. İkinci sorun biyopsisi 3+5'i.
Selahattin istersen panel bitiminde alalım
Tamam
sonra.
ama
Olur
onun
mu?
histolojik tartışılması
Tamam.
lazım.
Strictly speak in English, otherwise we don't understand.
Evet, peki. Panel bitiminde tartışalım. The pathological revealed 3+5 tumor with semivesical invasion. They didn't do a lymph node dissection during the operation. What will be the next treatment? Let's get the idea from audience.
You know, I just think it is
76% hormone and radiation therapy and 24%
you know, I'm
hormone
not
treatment.
sure that we need to do this decision immediately knowing the pathology because there's still, you know, to irradiate the patient immediately is connected with many complications and increased risk of complications. So even in this case, when it is upstaged, I will still believe, because as far as I remember, the margins were negative. So I would still wait for the first PSA 1 month, maybe 3 months after surgery. If it is not, or in not, if it does not mean that there is the persistence or recurrence of the tumor, I would maybe even wait for something.
Okay, thank you. You will see the patient's PSA results. It's 0.2 in December 2016, and it was in March 2017, 0.22. At that point, they decided to do a radiation therapy without pelvic lymph node area. Do you think that we have to include the lymph nodes in this radiation therapy area? We should ask this question to radiation oncologists, but
I think, first of all, by the time, I think the radiation, salvage radiation should be discussed because the PSA doubling time is very low. You can see from December to March is 0.2 and then 0.22. Well, you can discuss if you can wait or do adjuvant therapy. You have chosen adjuvant therapy. And regarding involving lymph nodes or not, there's no level 1 evidence that involving the lymph nodes give better survival. So radiation therapy is usually almost all trials that you can see, they include whole pelvis treatment. But there's no any level 1 evidence that says that including the lymph nodes will give better survival.
okay, thank you so much. Let's see the patient's result. This is the patient's PSA result. It rise very rapidly, and August in 2018, it rise up to 2.1. So do you want to see PSA doubling time? It was 5.25 months. It means less than 6 months. It has a high PSA doubling time. So what will you do after this one? Dr. Sedalar, do you agree with us to do a PSMA, or Dr. Marek, would you join us, PSMA PET with this patient, although recommendation is not strong, weak?
No, I would do a PSMA test.
Yeah.
I think this is actually the ideal candidate to do PSMA testing to see if there are occult metastases in either lymph nodes or both.
Recommendation'da zayıf gözüküyor. Her zaman recommendation'lar oturmayabiliyor her yere. Bu hastaya PSMA yapardım diyenler elini kaldırabilir mi? Panel PSMA yapardım diyor. Peki. Görüldüğü gibi salonun büyük çoğunluğu PSMA yapardım diyor ve hastaya PSMA yapılıyor. Görelim PSMA'sını. Bitiriyoruz. Right common ilyak bölgede. Yeah, 1 minute. Yeah. 1 centimeter metastatik nod, diğer tarafta bir tane metastatik nodu var. 2 tane. Bir tane de common iliakta. Peki son soru. Bir dahaki hipopetlere basar mısınız? 10 saniye. Ne yapardık? Last question. Follow up with PSA screening, hormonotherapy and salvage lymph node dissection. Evet, 116, 124. Bu arada panele soralım. What will you do with this patient? Will you do a follow-up PSA screening, hormonotherapy, or salvage lymph node dissection?
I would discuss it with the patient, but I would probably go for salvage radiation of the lymph
Radiation
nodes.
therapy,
It's not one of the options, but
salvage lymph node dissection.
no, probably not, because I
No.
don't think this is a bad candidate. He let's say every time he had a bad outcome of his results, and I would spare him the comorbidity of the salvage lymph node dissection, because I don't think we will cure him. But with radiation, you have at least a better option to delay the treatment, delay the disease, and try to avoid, for instance, hormonal treatment for some time.
I agree with Professor Sedalar. The salvage lymph node dissection is in this patient, although the salvage lymph node dissection indications are based in retrospective studies, is not a very good candidate because he has Gleason 8. He has also PCA development time very short, so he's not a good candidate for salvage lymph node dissection. Probably we'll discuss it with the radiation therapist to do radiation in this node.
Last question from the audience. 40% decided to do a salvage lymph node dissection. Would you consider to do a salvage lymph node dissection in this patient?
Yeah, me personally, it is, I think each local treatment, it means radiation and salvage lymph node dissection, is something that we have relatively weak evidence to do that. And I think first what we need to do is to explain the patient that to my opinion, the ambitions is just to postpone the hormone treatment. It is what we can achieve with that. And I agree that this is after radiation, so this is maybe not the good case for salvage lymph node dissection. But I probably would discuss with the patient. It depends how fat he is, in some individual situation, how risky he is for surgery, about his opinion. So I think there are much more parameters that you need to consider, and it must be very, very individual decision, I think.
Okay. Çok teşekkür ederim sabrınız için. Panelimiz sona ermiştir. Thank you so much for your contribution.
So we make 5 minutes break.